monitor a cycle for COH and IUI. For this, I would request our senior consultant, Dr. Swati, to kindly talk on this topic.
Thank you, Pravneet, and a very good evening to everyone, and I welcome you all. And in the coming 1 hour, I'll be talking about how to monitor a cycle for COH and IUI. Monitoring is the heart of COH and IUI treatment. Cycle monitoring guides us about follicular development, endometrial maturation, timing of trigger and IUI, the safety in terms of prevention of OHSS and the multiple pregnancy, mistime insemination. COH sounds simple. Hello. Hello. Am I audible?
Yeah, carry on.
Yeah.
Yes, ma'am, you're
Okay,
audible.
okay. COH sounds simple, but actually there are many obstacles, and a lot of drugs are available, various protocols are there, and it's very important to understand that each patient behave in a very different way. So in nutshell, it looks very simplified, but it is not actually that simple. So our key objectives of cycle monitoring is basically to ensure a mono or the bifollicular growth and to adjust the dose, whatever we are using, gonadotropin, letrozole, or the clomiphene, according to the ovarian response. Then simultaneously, we have to prevent the cycle cancellation in the both way to avoid getting poor and the hyper response. And we have to decide according to the cycle, the timing of trigger and the IUI. And again, it is very important to get the maximum pregnancy rate, which can be achieved with the combination of accurate monitoring and the appropriate patient selection. Then the cycle monitoring essentially should be very easy, reliable, it should be patient friendly, and it should not be very expensive. And most important thing is that it should be done by self, not by the ultrasound done by radiologist or ultrasound done by somebody else. So it is very, very essential component is it should be done by yourself or the clinician who is treating the patient. Ideally, it should be done with the transvaginal sonography, and we have to track the follicular growth, and the endometrial assessment is done. Color Doppler or the power Doppler is very important tool. Its assessment improves the pregnancy outcome. So if it is possible, it should be incorporated into the cycle monitoring. Then comes the hormonal testing is still not very much commonly, and it is not done for each and every patient, and it is to be done only in the specific cases where it is actually required. Then before starting the COH, a small short checklist to be completed. Like we have to look for the age, AFC and the AMH. The ASHRAE and ASRM both endorse that before starting COH, look for the complete ovarian pattern and the ovarian expected ovarian response. Look for the tubal patency and rule out any tubal and the endometrial factor. Then you have to look for the partner semen analysis, and duration of infertility is very important factor to decide that guides us about the success of IUI cycle. And the last and the most simple thing is patient willingness to frequent visits, because the IUI cycle monitoring involves multiple cycles. So before starting COH, you have to make sure that patient is willing to follow the cycle whenever you require her call after 2 days, after 3 days. So it is very important to make sure that before starting a stimulation, she should understand that she has to follow very frequently to the center.
Ma'am, do you recommend doing a tubal patency test for all the patients prior IUI? I mean, if there is no suspicion of having any tubal abnormality. A young patient, married life of 2 years, unexplained infertility, no suspicion of any tubal abnormalities, no prior history of TB, no prior history of any PIDs. Would you recommend doing a tubal patency?
It is a very good and the sound practice to assess tubal patency before starting any type of ovarian stimulation. The ESHRE, ASRM, and the other guidelines also document, irrespective of the semen source, whether it is a husband semen sample or even a donor semen sample case, tubal patency test is recommended. Only thing is that the modality you are doing tubal patency, whether it is HSG or it is by the sonohistography,
That's
could be different, but ideally it should be done. Then comes, there is no point to say, there is no feature of tubal blockage. Actually, we cannot suspect or we cannot say any tubal pathology because tube is not visible to the ultrasound unless until it becomes pathological visibility because of hydrosalpinx or any other tubal
endometriosis.
pathology. So a normal tube, which is of normal caliber with tubal block, we cannot see it on the ultrasound. So ultrasound doesn't guide us about the tubal patency. For that thing, we have to make sure tubal patency, and thereafter it is recommended to start stimulation. So a day two scan, so cycle monitoring starts with the day two periods, day two or day three, and the purpose is basically to decide the stimulation protocol to predict the ovarian response, and we have to rule out any functional and the functional cyst and the other pathology. In the
Swati, yeah,
yes, ma'am.
can I interrupt you?
Yeah, sure, ma'am.
I just wanted to make a comment about the tubal assessment that when you are planning an IUI, like for this topic, we are discussing monitoring for COH and IUI.
IUI, yes,
Then
ma'am.
that time you must do a tubal assessment. But if you are just doing ovulation induction for PCO or some anovulatory condition in young patients, short infertility, can skip that.
Yeah, that is okay. That is
Uh,
acceptable. But for IUI, performing IUI tubal patency test is mandatory. Either one of the fallopian tube should be
uh,
open. Yes, exactly, ma'am. Very true.
yeah, and if and one comment you made that you should be doing monitoring yourself.
Yes, ma'am.
So that may not be possible for everybody. So what do you suggest?
The centers who don't have their own ultrasound machine, for them it is not actually not very easy. But ideally, the person who is doing IUI, I mean, should have an ultrasound machine also because it is highly important factor. See, I mean, monitoring basically gives you an opportunity to rectify the cycle. I mean, you can adjust the dose, you know the patient biology, and you can change the medicine, you can trigger accordingly. I mean, the person who is doing ultrasound may not give you the exact clinical picture. I mean, you are the only one, clinician is the only one who gets the entire detail of the cycle. So your way of interpretation of the ultrasound could be very much different from the radiologist way of interpretation. So, I mean, that is how. Plus, another important thing is this is basically the patient confidence and a rapport making. I mean, way also. I mean, you do ultrasound by yourself, you check the follicular growth, you look for the patient uterus and endometrium. So your way of assessment can never match with the radiologist. So ideally, as far as possible, you should do it yourself. But if it is at all not possible, you can do that. You can call your patient to the radiologist center and you can join the radiologist to see, I mean, how the growth is there. So this could be another way actually.
Yeah, I think that this is what I was also trying to say, that if possible, then try to collaborate with one radiologist, so that sonologist, so that he is also conversant with your way of working, or he gets involved in the patient management, and you are also, used to seeing the picture on live on ultrasound machine, and then you can, slowly learn to take decisions, so you can work as a team
Hmm,
with
exactly.
somebody. Yeah,
So
if
on
possible.
the So on the baseline scan, we have to look for the size of the ovary and the volume of the ovary. Then we have to look for the antral follicle count. Antral follicles are actually the number of follicles in both ovary, the size varying from 2 to 10 millimeter. And we have to look for the stromal echogenicity. Ideally, in a normal ovary, it should be isoechogenicity. And again, if it is possible, we have to look for the stromal flow RI and the peak systolic velocity also. In the endometrium, it should be thin at the on D2 or D3 scan, and we could find a little bit of anechoic blood collection or the unshaded thick endometrium on D2 scan. So these are some of the pictures. I can, if they are visible on the screen, how to calculate the volume. For the volume, we have to take two different pictures. One is the longitudinal section, another one is the transfer section. In the longitudinal section, we take two measurement at perpendicular, and in the transfer section, we take the third dimension, and the ultrasound machine itself gives you the volume. Then the next picture is showing the picture of the how does the antral follicles look like. And the another two pictures are the D2 endometrial and the stromal blood flow of the ovary on D2.
Which assessment, ma'am, do you use more often, like a single diameter or a volume to
See,
analyze for probability or dose of?
mm. See, single diameter could not give you the exact bulk of the stroma. Can you give you the exact number of the antral follicle count? So this is always a wise idea to get a volume actually. So volume is basically a three-dimensional measurement. So it gives you a better how much is the bulky of the ovary and how much antral follicles are exactly distributed around the stroma. So that gives you a better picture rather than taking diameter in a one view only. For sake our convenience, we take diameter as our convenience, because many of us are used to of doing ultrasound for a very long practice, so that can give us some idea. But before freezing the picture on one frame, we used to actually scan the entire ovary, and then we fix a frame, and then we count the AFC. But ideally it should be the ovarian volume that gives us a better picture.
Fair enough,
So,
ma'am.
so these are the some of the day-two scan pictures which are most commonly seen. Like in the first picture, we can see this is the follicular cyst. In the another picture is basically the two ovaries. Both of the ovaries are lying in the POD, and they are basically very much close to each other. This is the picture of kissing ovary. So we can say this is a picture of early endometriosis. And the third and the fourth pictures are basically the corpus luteum cyst. We can see very big corpus luteum and the multiple echogenicity inside them with a thick wall. So this is two corpus luteum pictures are there, and the next one is basically the endometriotic cyst, and we can differentiate the look of the endometriotic cyst and the corpus luteum. The endometriotic cyst is basically a ground glass homogeneous opacity, and it is very much different from the corpus luteum, which is showing multiple echogenicity inside it. And the last three pictures are about the endometrium. In the first picture, some blood clots or the solid mass kind of pictures are there. So this is a picture where we can suspect a polyp, although we cannot completely say this is a polyp. So we have to exact notification of the polyp is done only once the endometrium is fully prepared. So this could be a picture of suspected polyp. We will have to look in the future coming days also. Then the second picture is basically the unshaded endometrium, and the third is basically a suspected intrauterine adhesions, because we can see multiple small fluid collections trapped in between the thick endometrium. So if this kind of picture is there, so we have to keep the possibility of adhesions in the endometrium, and that picture will be clear once the endometrium is properly developed. Then coming to the prediction of ovarian. Yes, ma'am.
Go back to the previous picture. Yeah, I think this is a very important slide. Are you going to discuss if you see this on day two, what you are going to do? Like if you see a follicle, I mean, these are
Okay.
the commonest questions, what comes to the mind of a person who is going to start a cycle. So if you could take one by one all this, then I think
Okay.
that would be good.
Oh, okay. Sure, ma'am. I have not taken that much of detail, but I'll definitely cover it. There is no problem. So if we see the Yeah. See, if the follicular cyst is there on the D2, it means this cyst is persisting from the previous cycle. I mean, this is not a fresh follicular formation. This is existing from the previous cycle. If some cyst kind of thing is already existing, so we'll not be get a proper recruitment of the follicle in the present cycle. So this is a good way not to give stimulation in the same cycle. And we have two options. Either we ask the patient to wait for some time till the to wait for this cycle till the follicular cyst disappears by itself, or we can add oral contraceptive pills so that the size of the size of the follicular cyst disappears very rapidly. And now the thing is that very recently, if I mean what we are using, because this follicular cyst does not let the estrogen level and the FSH level come to the baseline. So what we can do, if we see a follicular cyst is there, then we can start oral antagonist medication, that is the elagolics, that can very rapidly suppress the E2 level to the baseline. And after giving 1 week or 10 days of elagolics, we can start COH if patient is in actually a very much hurry to start the cycle. So this could be one of the way to deal the follicular cyst. And the next one is basically the corpus luteum cyst. So corpus luteum cyst are there, then definitely we have to wait till the corpus luteum subsides, because and we have to put a color also just to see the how much activity is in the corpus luteum. If the corpus luteum is taking full color, then definitely we have to wait until the corpus luteum vascularity is reduced and the corpus luteum regresses. Then only we can start the next cycle. And endometriotic cyst, definitely we cannot do much about it, because then we have to see there is no is there any other dominant follicle or there or not. If there is no other dominant follicle or there is no other pathology, only the thing is that the single endometriotic cyst is there, then we can start the stimulation. And I mean that's why in the early endometriosis, if there is no big cyst, then we can start the stimulation.
And if endometrium is not shed, or if you suspect something, polyp or some adhesions.
Uh, in polyp, there is no problem. We can start, suspected polyp on day 2 is not a contraindication to start ovarian stimulation. We can start ovarian stimulation. But if we find a very large size of polyp, like more than 1 centimeter size of the polyp, then definitely we have to do hysteroscopy to remove the polyp. But if the size of the follicle is a smaller, I mean, in general, this is said, if it is less than 1 centimeter, then we can proceed with our IUI cycle. And then about the unshedded endometrium. In unshedded endometrium, most of the time, unshedded endometrium is associated with any of the functional kind of cyst is there. If it is not associated with any cyst, then we have to wait for 1 or 2 days. It will regress, it will shed by itself, then we can start stimulation. So if it is unshedded endometrium, we should not be very much hurry to start stimulation. Like in a routine way, we start stimulation from the day 2 only. If endometrium is not shedded, we can wait for a couple of days, and till endometrium is there, in most of the cases, there is no spontaneous recruitment of the follicle is there. So we can still wait for a couple of days, then we can start stimulation. And in cases of suspected adhesions, so that picture will be clear once the endometrium is there. So we will have to wait and look for the endometrium later on.
Basically, you have to assess the patient before starting the COH cycle, so that you are not getting any surprises. But if you still get the surprise, maybe you can hold on the gonadotropins and give only oral ovulogens and start the cycle, so you don't waste too much of patient's money. I think that's important. And then you see on 8th day, many times endometrium just clears up and is triple line. So during menses, a lot of artifacts may be there.
Exactly.
Yeah.
Then the prediction of normal ovarian response and what protocol should be used. The baseline ovary of a baseline ultrasound of the normal ovary is basically the volume is between 6 to 10 cc and the AFC is 8 to 10. Peak systolic velocity is between 7 to 10 and RI is 0.5 to 0.6, PI is 0.9 to 1.2. And in this ovary, our target is basically to get 2 to 3 follicles after stimulation. So here we can use the protocol. Either we start with the letrozole 2.5 to 5 milligram daily from day 2 to day 6 or day 3 to day 7. This is one of the most safest kind of stimulation, I should say. And or we can use the clomiphene citrate 50 to 100 milligram daily. Again, the from day 2 to day 6 or day 3 to day 7. Or we can have the mild gonadotropin 75 international unit daily combined with either letrozole or the clomiphene. So a combined protocol gives a better pregnancy rate as comparison to the letrozole or the clomiphene alone. Then comes a sequential protocol where we start letrozole or the clomiphene citrate from day 2 to day 6. Then we add 75 units of gonadotropin from day 7 to day 8. Here the benefit is that because of the sequential protocol, there is some recruitment of the follicles occur with the letrozole and the CC. That is how it reduces the total gonadotropin consumption and it improves the endometrial sensitivity also. So these are the all protocols for the normal ovarian responders. Then,
Ma'am, what is your first choice, letrozole bar CC, for a normal responder?
see, my personal choice is basically a sequential protocol. I most of the times start with the letrozole and then I at the finishing of letrozole, I call the patient for ultrasound, and if I see there is no dominant follicle, then I continue letrozole for another with high dose for another 5 days. Then I add gonadotropin.
Basically, step up
Yeah,
protocol.
it is basically a step up
That
protocol.
would be more true for PCO patient, but
Yeah,
yeah,
yeah.
normal responder patients perhaps
Generally, normal responders
some
give a
point.
very good response even with a 2.5 mg letrozole, and we don't have to escalate the dose. But if once the lead follicle is seen with the letrozole, adding gonadotropin definitely improves the endometrial receptivity. So my choice is basically to complete letrozole, and then from the very next day you can add gonadotropins.
And what about CC? Why don't you prefer CC?
CC is actually before that before coming letrozole, we were using CC right and left. But there are so many benefits of letrozole. CC has basically highly anti-estrogenic impact. So plus it is also associated with the multifollicular development is there. Side effect, anti-estrogenic effect and endometrium is there, and then luteal phase defect is also seen. Sometimes LUF is also associated with the CC. So many side effects of clomiphene are there, which were actually, you can say, remain unnoticed till letrozole was there, because at that time CC was the only option. So now we have an option for letrozole. So our choice is basically, our focus is basically now shifting from CC to letrozole. Then coming to the poor ovarian response. So the predictors for poor ovarian response on ultrasound are the ovarian volume is less than 3 cc, AFC is less than 3, ovarian peak systolic velocity is less than 7, RI is more than 0.7, PI is more than 4. See, ovarian blood flows are very, very important in prediction of ovarian response. A good ovary has very high systolic velocity, and if the systolic velocity is less, it means this ovary is not going to respond very good. If RI is high, RI means the resistance to the flow of the ovary is high. That means again this ovary is not going to give you very good number of follicles. So this, I mean, I always try to make sure that somehow I should learn, and everybody should learn how to assess PSV and the RI, because this is one of the very major predictor of ovarian response. So this is very, very important thing. It's very, very easy to understand, and it's very easy to do on the ultrasound also, actually.
But
So
I
for
think
poor,
it needs a good learning curve.
yeah, obviously it requires a learning curve, but once you know it, you can actually predict ovarian response very easily. then there is no universally accepted single best protocol for the poor responders, because most of the data is from the IVF, not from the IUI cycles. And so we have to use our own judgment and the experience for the deciding the protocols. So it could be a milder stimulation protocol where we start with the 75 units of gonadotropin combined with the letrozole or the clomiphene, or we can use only gonadotropin protocol, 75 to 150 international unit. And the evidence, I mean, which is from our own Indian guidelines on the PUR, says that both, either it is only gonadotropin or a milder stimulation gives you the equivalent result. So this is your choice, what protocol you would like to choose, you can choose it. Then comes the prediction of hyperresponse. Hyperresponse has actually the two things. One is the PCO ovary and another is the hyperovarian responder. So it's very important point to differentiate between the both. The PCOS basically in PCOS, according to the revised guidelines, we have to look for the follicle number per ovary. That is now more than 20 follicles in at least one ovary. Ovarian volume is more than 10 cc in at least one ovary. And if we look into the one cross section, if we are not able to count the follicle in the entire ovary, then it is also a good practice to look the entire follicles in the one section. If they are more than 10, along with the ovarian volume also more than 10. So that is how the FNPS is seen. And so this is basically a criteria to label a patient as PCOS. Then not every patient is PCOS, but a hyper responder. Hyper responder means when the ovarian volume is more than 10 and the AFC is more than 10, peak systolic velocity is also more than 10, RI is less than 0.5 and PI is less than 0.8. So both the patients, either this is a PCO or the hyper responder, like the second picture is basically of hyperovarian responder, where this is very much different from the PCO ovary. But both the patient are at risk of getting multifollicular development in OHSS. So we have to be very much cautious in these type of patients. And the protocol which we use in these patients are the letrozole based protocol. These are the safest protocol. We can start with a 2.5 milligram daily from day 2 to day 6. Maybe the other alternatives could be we can start with a 5 mg or we can use a step up escalating protocol in case of PCO patients. Or if the letrozole is not working in PCO patient, then we can use a low dose clomiphene citrate, that is from 25 to 50 milligram daily. Or we can use a low dose step up, that is gonadotropin 37.5 units, starting from day 3 for 5 to 7 days. And then we do ultrasound and decide accordingly. Or we can use a sequential mild protocol, which is the combination of letrozole 2.5 mg along with a very low dose, that is 37.5 units of gonadotropin, that is the FSH protocol. So these are the some of the protocols which we can use for the PCO as well as the hyper responders. Then coming to the monitoring. So after starting our protocol, whatever is it is a letrozole or the gonadotropin alone or in the combination, we have to start monitoring, which is generally done on day 8 to day 10. And we have to look for the follicular growth number and the endometrial thickness. How to measure a follicle size? We have to take the 2 or the 3 dimension and we have to take the mean of that. The average growth of the follicle is 1 to 3 millimeter per day in the follicular phase. Then endometrial thickness, this is measured at the widest part and this is which is perpendicular to the endomyometrial junction, as we can see in this picture. And in a proliferative phase, the thickness increases at the rate of 2 to 3 millimeter per day, and it should be a triple line endometrium. Triple line endometrium means, like in this picture, the center part is basically the middle layer this is the echogenic lumen, and around it is the hypoechoic. Like we can see, this is the area, hypoechoic area. Surrounding the lumen is the endometrium functionalis, and the outermost is basically the hyperechoic line, which is the endometrium basalis, from where the endometrium regenerate. So this is how a triple line endometrium pattern is visible. Then what is our target? Once we see a dominant follicle, it keeps on increasing in size, and we continue giving our protocol, whatever is gonadotropin dose is continued. And our basic target is to get a mature follicle. And the mature follicle should be round, thin wall, without any internal echos, and the ideal size is 18 to 22 millimeter. And the endometrium should be more than 7 millimeter and a trilaminar pattern. But in the lateral cycle, follicular growth is a bit slower, and generally we get a monofollicular development. In the clomiphene cycle, endometrium delays a bit. I mean, the endometrium remains thinner, and it is not corresponding to the follicular size. Plus, we get a multifollicular response also. In the gonadotropin cycle, that is the best cycle because it gives a best good synchronization between follicle and the endometrium. But again, here there is a risk of the multifollicular response. Then comes a criteria to trigger the cycle. So the time to trigger is basically should correspond with the start of LH surge. So there are two important things. One is the follicular size. That could be 18 to 20 millimeter size along with the endometrial thickness more than 7 millimeter. But again, very important thing is to look for the cervical mucus also. Cervical mucus actually gives us a clue about the estrogen levels that are produced by the follicle. So this gives us a clue about the functional maturity of the follicle also in an indirect way actually. But in the gonadotropin cycle, standard size is basically 18 to 20 millimeter, but not in every cycle the cutoff remains the same. Cutoff can be changed. Like in the gonadotropin cycle, 18 to 20 millimeter diameter is ideal. In the clomiphene cycle, we have to wait till the endometrium matures. So size could be 20 to 22 millimeter. Again, in the letrozole cycle, size could exceed, and it may take little more time to reach a good endometrium. So size could be up to 20 to 22 millimeter. Then the drugs we use for the trigger is either we use urinary HCG, which could vary from 5,000 to 10,000 unit, or we can use the recombinant HCG 250 micrograms subcutaneous. GnRH agonist can be used in very selected cases, not in a routine practice. As I was already saying that the follicle size and endometrial thickness is basically just anatomical maturity. It doesn't give us an idea about the function of the functional competency of the follicle. So this functional competency can be evaluated by a Doppler flow study. So in the Doppler flow study, we have to look for the follicular, endometrial, and the uterine vascularity. So that gives us about the physiological maturity of the follicles, and it also predicts the uterine receptivity. So that is how this can be combined along with the size and the endometrial thickness of the endometrial thickness. Then a little more detail about the follicular Doppler flow. So how to measure a follicular flow? So first we have to focus on perifollicular vessels. Like we can see in this picture, this is the follicle. We have to localize these perifollicular vessels. So what are the perifollicular vessels? So perifollicular vessels are the vessels that obliterate the follicular wall with color. Once you put the color, and it will totally obliterate the follicular wall, you'll not be able to see the follicular wall. If you are able to see follicular wall and the vessel is also visible, it means you are not focusing the perifollicular vessel. Once the perifollicular vessel is there, then follicular wall will not be visible. So this is basically a point how to focus the perifollicular vessels. And if the blood vessels are very scanty, they are very lesser flow is there, then definitely the simple color Doppler could not give us an idea. So we have to put a power Doppler to get vascularity more effectively. So as the follicles mature, its flow to resistance should fall. So Ra keeps on falling and the systolic velocity of the flow keeps on increasing. It should get good vascularity. The resistance should fall and the velocity should increase. So these are the two important things for the follicular maturity. in the cases where RI resistance increases, it means the follicle is not getting good oxygen. So that follicle will not give us a good egg. So the maturity of the follicle will not be there. And similarly, if the systolic velocity is not very good, the follicle will not get good vascularity. So again, this follicle will remain immature and incompetent. So that is why the pregnancy where the PSV is less and RI is high are very less. Then what should be the exact value of Doppler before giving the maturation trigger? So vascularity wise, it should perifollicular vessels should cover at least 3/4 of the follicular circumference. Perifollicular vessels RI resistance index should be between 0.4 to 0.48, and the peak systolic velocity should be more than 10. As we can see in this picture, the follicle is surrounded by the vessels, and if we look into the detail, the peak systolic velocity is basically the around 18, and the RI is 0.49. So this follicle is basically ready to trigger. So that is how we we give the trigger on the basis of color Doppler. A consistently
Ma'am,
rising, yeah, you want?
ma'am, I wanted to ask Jindal ma'am,
Hmm.
like, how significant is it for an IUI cycle to do Doppler?
Actually, if you are able,
Practically, how
yeah,
frequently? I mean, the learning curve is huge. One, two. If you're not able to do it, should we actually ask a radiologist to do it for us, or it isn't that important?
see, the problem is if you are able to do color Doppler and good study, then it is very helpful. But there's many technical problems also besides the learning curve. There are other technical problems depending upon the ovarian position, ovarian, whether your machine has to be actually very good to give that kind of color settings have to be right. And so all those things are limitations of color flows. But if you are able to do, it's certainly helpful. But I can't say it is mandatory. It is definitely helpful, but not mandatory.
Okay, so then comes about the Powell Doppler evaluation of endometrium actually. So along with the follicle, endometrial vascularity also holds the equal importance. So actually the endometrial vessels are the spiral arteries that arises from the myometrium and goes into the endometrium. So according to the vascularity, there are four zones are there. Zone 1, as we can see in this picture, this is the 2 millimeter thickness of the myometrium which surrounds the endometrium. Zone 2 is the hyperechoic outer layer. Zone 3 is the hypoechoic inner layer. And zone 4 is the endometrial cavity. So a good endometrium is basically where the vascularity exceeds and extend up to the zone 3 and the zone 4. So this is the time where we have to trigger the follicle. So if I combined all the thing, so I can say the ideal criteria to trigger is when the follicle is more than 18, it is surrounded by more than 3/4 of the peripheral blood vessels. RI is 0.4 to 0.48. Peak systolic velocity more than 10. Cervical mucus is also there. Endometrial thickness is more than 7. And the vessels extending up to the zone 3 and zone 4. And PI is, is 0.8 and RI is 1.12 to actually. So these are the ideal criteria to trigger the follicle.
But
Then comes
Acha, just go back. The more important part is the coordinated, development of a follicle and endometrium. If we just leave the color Doppler aside, if the follicle, has matured and the endometrium has not picked up, then follicle will not rupture. You can easily wait for 1 or 2 days for HCG. And if follicle is small and the endometrium is more mature, then there is a risk of premature rupture in these patients. So coordinated development of follicle and endometrium is very important for success of IUI cycles.
exactly, ma'am. So then comes trigger to insemination time. So once we trigger the cycle, it causes LH surge, oocyte maturation, and the ovulation is there. So time to insemination is basically shortly before the ovulation. If it is a single IUI cycle, the best results are seen at the 36 hours after trigger, although we have a window of 34 to 38 hours. And if we are doing a double IUI, so first IUI to be done 12 to 18 hours after the trigger, and the second IUI is at 36 post trigger. And the evidence says there is no difference in the success rate in single versus double IUI, except in some male factor etiology is there that can give us a little bit better results in cases of the double IUI. Then comes if it is a GnRH agonist trigger, then ovulation is slightly earlier. So IUI timing can be little bit preponed. I mean, we can do IUI between 34 to 36 hours post trigger rather than exactly 36 hours post trigger. And if a cycle is followed by the urinary LH detection, then IUI is done between 24 to 26 hours after LH positivity. Although in general nowadays we are not doing it with the urinary LH monitoring, but there are some patients who actually monitor these urinary LH and then they decide for IUI. Then comes about the ultrasound signs of imminent ovulation. So signs of imminent ovulation that we can see on the 24 hours after the trigger if we are doing a double IUI cycle. So we can see a thin walled, follicle is thin walled, anechoic, and this is surrounded by a sonolucent halo. And sometimes we are able to see the cumulus. I mean, this is a picture showing the cumulus also. Cumulus 24 to 36 hours before the ovulation, or there are separation or the folding of the inner layer. This kind of picture is seen somewhere between 6 to 10 hours before the ovulation. And there are changes into the endometrium also. The triple line endometrial pattern progressively becomes thicker, homogeneous, and hyperechoic. So these are the signs of imminent ovulation that we can see on the first day in cases of the double IUI cycles. Then signs of the ovulation, how we confirm, we can see the disappearance of the collapse of the follicle, as we can see in this picture. The margins becomes irregular, or we can see the free fluid around the ovary, or there is a presence of, along with this, the presence of hyperechoic smooth secretory endometrium is also there. So these are the signs of confirmation of ovulation. So in this way, we have completed a normal and natural monitoring, which we have done. I think if there are some questions we can take, and if there are no questions, then we can proceed to the next section, which is a troubleshooting for during the COS and IUI, and the what is the evidence says about how to handle the problems.
Swati, how do you time this with the IUI? I mean, see, practically speaking, there are many patients, who have been told by their doctors that rupture to hua nahi, wait, and then, patients keep on bothered ke rupture nahi hua hai, and why should IUI be done? So, how do you time it? You time it with HCG, or you time with rupture, and how do you do it?
See, it is very difficult to time it with rupture. So ideal approach is basically to time it with HCG. I mean, this is the only criteria that you can control, because time to trigger you can modify according to the follicular response, according to the cycle. But you can never predict when the follicle is going to rupture. This is a range of the range is there, that after HCG, the time of the rupture is somewhere between 36 to 48 hours, or maybe up to 72 hours. So you cannot predict the timing of IUI can never be predicted according to the rupture. This is predicted according to the time of trigger, that you expect that by that time follicle will be rupture, and the insemination time is basically is calculated before just before the ovulation.
So you just time it with HCG. You don't bother
Yeah.
about whether it's ruptured or not.
Ideally, it should get rupture, but if you once you decide how to do IUI, that can be calculated only on the basis of
Yes.
trigger HCG. So we'll take the problems one by one. So let's start with the first case.
And
This
I
is
request all the audience, if they have any question, they can interrupt and ask. Yeah.
So this is a case of 28 years old, normal ovarian reserve. The cycle was to start with letrozole and the HMG stimulation. On the day 10, a dominant follicle of 17 millimeter was there and endometrium was 8.6. Homogeneous endometrium was there. And patient reports mild pelvic pain and discomfort. So what should we think about? Most likely, we are dealing with the problem of premature LH surge. The endometrium is homogeneous and patient is having mild pelvic pain and discomfort. So this could be there could be a possibility of premature LH surge. This occurs in 25 to 30% of the stimulated cycles. There is a risk of early ovulation, and that is how the poor timing of IUI is there. So success rate are basically lesser. So ultrasound findings suggestive of LH surge are a collapsing follicle or a free fluid around the ovary or a loss of regular follicular margin or the endometrial echogenic changes. As we can see in this patient, the endometrium was homogeneous while the dominant follicle was still there. So there could be a possibility of premature surge. So how should we proceed? The possible causes could be too early rise, too rapid rise of estrogen levels, high sensitivity of the patient pituitary, like some thin, lean PCOS kind of patient have very high sensitivity pituitary, so they are very prone to get premature LH surge. Or if we start monitoring in late phase, so that could be one of the possibility. And the corrective steps are basically, if we suspect premature LH surge, then we can immediately trigger the cycle and do IUI within 24 hours. Or we can confirm it by the hormonal level. We can ask for the serum LH levels. If the serum LH levels are more than 12 to 15, so plus, so this is a definite sign of the premature LH surge. And in most of the, so if the LH surge is there, so then we can give trigger immediately and plan IUI within 24 hours. And these cycles require more frequent monitoring. So in the future cycle, we have to be a little more cautious about that. Or we can add antagonist to prevent the premature LH surge, as we do in cases of IVF stimulation.
Do you think this patient is likely to get pregnant?
LH surge probably has already happened. We can rescue the cycle by giving trigger and plan IUI within 24 hours, but the success rates are a little bit compromised.
Yeah.
I mean, this is not only a matter of rupture of follicle. This is basically the implantation that is compromised in cases of premature
So
LH surge.
maybe you can ask them to have natural relation this
Yeah,
cycle
that could be also a way to rescue the cycle. Yes, exactly. So that could be a way.
and avoid an IUI this cycle.
Yeah. So the thing is that once you suspect a patient like good endometrium is there and still the follicle is not ready, so you always ask the patient to have a natural relation. At least if the follicle gets rupture or the patient get premature surge, there will be a possibility of conception. That if you have not triggered the cycle, but still the patient has taken a relation, has planned a relation, so there could be a possibility of natural conception. So quickly moving to the next case, which is about 35 years old female, AMH is 0.9, AFC is 6 to 7. This is only gonadotropin 75 cycles. On the day 9, we saw on the ultrasound two follicles of 8 to 9, of two follicles of 9 to 10 millimeter diameter, and the endometrial thickness was 5.5 only. So should we increase the gonadotropin dose? So will it help now? On day 9, two follicles, 9 to 10 millimeter, and the endometrium is 5.5. AFC was in the normal range, 6 to 7, although AMH was 0.9 only.
Pravneet, what do you think?
Yeah,
Pravneet?
maybe we can actually add urinary FSH. You can increase the dose or you can add urinary FSH.
I think it's basically the question of adding FSH. Either you add HMG or add FSH. I think that's not going to make much difference. But the basic thing is this patient needs more FSH.
Yeah, exactly.
Yeah.
So basically here we are dealing with the problem of slow growing follicles or the poor response.
And
So
what size do you expect on day 9, Swati?
so on D9 after 4 or 5 days of gonadotropin, ideally it should have been around 12 millimeter.
Yeah. So if it's less, apparently less growth, because you don't have too much of margin in IUI cycles. You have to mimic the growth pattern to a natural cycle. So except in PCO, where you can be a little deviate from the cycle, in a natural, most of the IUI cycles, you believe that you are doing it for unexplained infertility. There you have to mimic a natural cycle. The growth trajectory of the follicle should be like that.
Exactly. So, how we label a patient as poor ovarian response? If the follicle size is less than 10 to 12 millimeter on day 8 and day 9, or the no follicle of more than 14 millimeter by the day 11 or day 12, or the endometrium remains less than 6 by mid cycle, or the E2 levels, although they are not monitored in every cycle, but if they are monitored, they remain lesser than the expected levels. Then the possible causes of this particular response could be suboptimal starting dose of gonadotropin, as the ma'am was saying, or it could be because of just poor ovarian reserve. Obesity and insulin resistance could be one of the factors. Thyroid and the prolactin and vitamin D deficiency are again important medical disorders leading to this type of response, or the concurrent use of medications like letrozole-induced follicular delay could be one of the factors. So the corrective steps could be either we can use a step-up protocol, or the increase the dose of gonadotropin could rescue the cycle, or we can add letrozole in the next cycle, because letrozole along with the gonadotropin can improve the FSH sensitivity in cases of suboptimal responders. If the poor response is, see, this particular cycle was only gonadotropins. We can see the poor response in the letrozole cycle also.
Cycle was only gonadotropins. We can see the poor response in the lateral cycle. Swati, Swa- Swati,
There is some echo in the system actually.
yeah, Pravneet?
हाँ जी मैम.
You
I
are
think now
okay?
it is clear.
Yeah, it's gone. It's gone. The
हाँ
echo is
जी
gone.
मैम.
No, there was a lot of echo, so we don't know from where it's coming. Okay.
Okay, so if the poor response is on the letrozole cycle, then we can increase the dose from 2.5 mg to 5 mg and then to 7.5 mg, or we can extend the same dose for the longer duration, like 5 to 9 days, or we can combine gonadotropin along with the letrozole to get the better follicular response. So moving to the third case, so here we have a 30 years old female undergoing ovarian stimulation with letrozole 5 mg, and on day 10 follicle was 18 millimeter, but the endometrial thickness was only 5.8 millimeter. So what should we do? Should we trigger it now, or should we wait for the endometrium buildup?
I think in general, this kind
Wait
of
for the
discordance is
endometrium to build up.
indicative of a very poor kind of follicle, as well as the discordance of
Lateral.
follicle and endometrium, and even a very early development of this sized follicle is also not a sign of a very healthy follicle.
Very healthy follicle, yes.
So I think maybe you can drop the cycle or just observe the cycle without any much intervention. Because see, IUI is a costly and invasive procedure. So you should be doing only if you think that the possibility of a pregnancy is there and your cycle is satisfactory. Ovulatory cycle, if it is not satisfactory, I think it's better to drop than to proceed with IUI cycle.
Okay, ma'am. So the possible causes of thin endometrium, it could be CC or the letrozole induced. It could be because of the low E2 level from insufficient stimulation, could be a poor uterine perfusion seen with the post-myomectomy and the adenomyosis kind of uterus, or it could be because of the chronic endometritis and the intrauterine adhesions. So in the, I think should I go for the detail or should I skip this part?
Yeah, I think we have already perhaps discussed also.
Cover. Yes, yes. So the moving on to the next case, which is a 32 years old female with previous 3 IUI donor insemination cycles failure. Now she wants to go for the last IUI cycle, and the patient request is ultrasound as well as the hormonal monitoring before IUI. So this was a lateral plus gonadotrophin cycle on day 11. Follicle was 20 millimeter and the endometrium was 8.2 millimeter, triple line endometrium, as we can see in the picture. And E2 level was 534 and progesterone was 1.6. So does elevated pre-ovulatory progesterone impacts the success of IUI also? And should we proceed for IUI in this patient or should we cancel the cycle?
I think it may be a sign of early LH surge, so you can give HCG and do IUI 24 hours later, or confirm your whether the LH surge has started and then do. But early progesterone would interfere with the
Yeah,
implantation.
it impacts actually with the implantation.
Yes.
So
Yeah,
the
actually, these are the causes because you never monitored so many IUI cycles. So these are the causes which may be there for poor pregnancy rates with the IUI cycles.
These are the factors which be, but we because we do not go for the hormonal monitoring, so we never come across. I mean, what abnormalities were there into
Hormonal
the
monitoring
cycle?
is not done.
Yeah,
Yeah.
yeah. Otherwise, the cycles become too costly.
Yeah, exactly. So, what are the risk? Which patients are at risk of having high progesterone before the trigger? So, this could be protocol related related factors or the patient related factors. In the gonadotrophin cycles, multiple follicular growth itself, high E2 levels and cause premature LH rise. CC cycle, high endogenous FSH levels remains for 5 to 7 days. Again, the same factors are there. In the letrozole cycle, if the dominant follicles, that is more than 20 millimeter size cycle follicle, remain for more than 48 hours without a trigger, that itself can cause LH upregulation and the progesterone rise occurs. So this is again important thing to note, that endometrium and the follicle should develop hand in hand. Otherwise, the cycle, if it got in asynchronous, then it does not give us a good result. Then the patient related factors are the young patients, highly sensitive ovaries like PCO are more prone for premature progesterone rise. The poor responders, if the stagnation of the follicle occurs for more than 48 hours before the trigger, that again a sign of prolonged stimulation and a premature rise of progesterone. So can we move for a little bit detail about the hormonal monitoring? So E2 levels, if at all we are doing, should be done when the follicle size is 14 to 16 millimeter. And at that time, we expect E2 levels of 150 to 200 picogram per follicle. These values are slightly lesser in the letrozole cycle. If lesser values are in the gonadotrophin cycle, we can increase the dose or we can delay the trigger. LH should be checked only in cases where premature LH surge is suspected. If the LH levels are more than 10 or the double from the baseline and the progesterone levels are normal, then we can immediately trigger the cycle and save the cycle for IUI. If the LH surge is there, means LH levels are more than 10 or the double from the baseline plus progesterone has already raised, as in our patient 1.6 level was there, then we should cancel the cycle. Then the progesterone levels are done only in cases where there is a doubt of premature luteinization. Should we discuss one more case?
I think if you have any questions, anybody or comments, please make. Dr. Deepa, would you like to say anything?
I think Swati has made so many things too much clear. I am taking all the pictures actually. So I was involved in that.
Thank you so
But
much, ma'am, for your
and
encouraging words. Thank you, ma'am.
I have actually learned a little, two, three things new here. How to monitor with the hormonal triggers, hormonal cycle, and about the color Doppler. I never thought that that would be so helpful. But Swati, what is your practical experience? Do you feel that you are doing these color Dopplers and the pregnancy rates have increased or your cancellation is low?
Yes, ma'am. Perifollicular flow is not very difficult to see. I mean, it
Hmm.
just need a little bit adjustment of your ultrasound knobs. You can do it. There is no problem. RI, getting RI needs a little bit tricky because we have to adjust the gate size and all these things. So that could be a little bit difficult. Getting peak systolic velocity again is not very much difficult because you get a very clear-cut
Pulse
curves.
Doppler, right?
Graphs are there. It's very easy to get. It's not very difficult thing. And another thing is that endometrium, you can see vascularity up to zone 3 and zone 4 is very
Four.
easy to see. It's not
Hmm.
very difficult. I mean, what I adopted a practice, I started following, noticing vascularity after giving the trigger. See,
Okay.
once the trigger was there and the follicle was ruptured, then I started learning how to do a Doppler ultrasound. Then
Hmm.
I follow the same thing before giving the trigger. So that is how I developed my practice of doing color Doppler on the follicles.
And that has helped increasing the pregnancy rate
Uh,
in
preg-
IUI cycle.
Ma'am, pregnancy rate in IUI basically is basically a patient selection factor are the most
Yeah, yeah,
important thing.
that I
I mean, this
agree.
is the one important criteria. Unexplained infertility, long duration infertility will not give you very good result.
Hmm.
Poor ovarian response will not give you very good result, irrespective of very high quality follicle. Very good endometrium will not give you a very good result because there are other factors are also there which contributes the success of IUI. You can make sure a good correlation between endometrium and the follicle, and you can exactly calculate the time of trigger, but there are other factors also which contribute to the success of IUI. So, but
And where the blood flows are not good, is there anything you can help the patient with?
actually, we cannot help it out. This is
Hmm.
basically a guide to give us an idea whether this cycle from the follicular, from the ovum point of view is going to be successful or not. So we cannot
Hmm.
modify the cycle. Only thing is that we can drop the cycle. This is the
Okay.
only thing we can do.
This is the only thing which you get from the color Doppler. Hmm. Okay. Okay. Yeah.
Timing, etc. Also, they are helpful. When you are doubt whether to give trigger today or tomorrow, then sometimes
Okay.
color doublet does help you.
That really helps sometimes,
That really.
yes.
Okay. So that is a big factor actually. So
But
you mean if
not, it's not mandatory. Many times, develop an eye like we always work with black and white only from the
hmm.
very beginning. So I think somehow black and white also gives a fairly good idea.
Exactly, ma'am. I mean, the key of putting Doppler is basically you should have a very good grayscale
Machine.
ultrasound. I
Yeah.
mean, that is the
Yeah.
best thing.
Yeah.
I mean, there only you can put the color. If your black and white focus is not good, then you cannot get a good color also, even
Yeah.
despite the follicles getting good colors.
Yeah.
Hmm.
So, should I proceed or should I stop
I
now?
think we have finished our time. I think this question you can take, but that's
Okay, okay, fine. So this is a case of 34 years old, normal ovarian reserve. She was going and stimulation with CC and HMG. HCG trigger was given at 19 millimeter follicle size and 8.8 endometrial thickness on day 13. A single IUI was planned on 36 hours and 36 hours later, follicle was not ruptured and there was no free fluid. Endometrium was normal. So can we re-trigger this follicle now? And this is the one of the very commonly faced situation. And many beginners do re-trigger also.
but
So,
usually doesn't help. We have also tried in the beginning when we were doing a lot of
Doesn't
IVF,
help.
but it doesn't help.
okay, so here the problem is basically the luteinized unruptured follicle. The incidence in the natural cycle is 5 to 10%, and in the stimulated cycle is 10 to 15%. This is commonly seen in the clomiphene cycle, endometriosis, PCOS, and use of NSAIDs. So, a normal ovulation basically needs
I
LH
think we
surge.
can now skip this and
Okay,
you
okay,
can
fine.
wind up now. Yeah.
I'm this fine. Okay. So I think I'll skip. So I will definitely like to discuss the common pitfalls in IUI cycles. The common pitfalls are basically waiting too long to trigger or ignoring the early LH rise sign. Then we proceed despite getting more than 3 follicles, or we do not focus on the endometrium, we just focus on the follicle size, and inconsistent scan intervals. So these are the common pitfalls in IUI cycle monitoring. So here I conclude with some scientific evidence-based conclusions. Always use stimulated cycles for IUI, not a natural one, because that will not going to give you a good result. Then cycle monitoring modality, ultrasound is the monitoring tool, and routine E2 levels is not recommended for anybody, for everybody, only in the selected cases. Practical monitoring schedule starts with the day 2 or day 4 scan on the stimulation day, day 5 to day 7, then thereafter every 1 to 3 days according to the response of the follicle and the endometrium. Trigger when the lead follicle is 18 to 20. IUI generally is performed, single IUI, it is performed 32 to 36 hours after the trigger. And cancellation, according to the safety criteria, ASHRAE says you have to cancel the cycle or convert the cycle if you get more than 4 follicles or high E2 levels or clinical picture indicating of OHSS. So that is all I have to say about cycle monitoring for IUI. So here I conclude with our announcement of the next class, which is on 19th of December, which is about IVF stimulation protocols. We have already covered about the IUI cycle stimulation for IUI. Now we are moving to the IVF. So the next topics to be taken by Dr. Nidhi, and under the expert opinion of Dr. Umesh Jindal, and this is the IVF protocols, what a gynecologist should know. So that is how I conclude this.
Thank you, ma'am. That was an amazing talk.
Thank you, Pratham.
Dr. Umesh Jindal, ma'am, that was a good presentation, Swati. I just wanted to ask ma'am that keeping in mind the cycle length of a patient, like some people have 24, 26-day cycle, and some people have 30 to 35-day cycles, because we start monitoring from ideally day 8, that is fixed. So even sometimes I have like triggered at around day 14, so I think we can always wait. We have to keep that also in mind, no ma'am? The cycle, some people have prolonged cycles without PCOD, I'm talking about.
You have to take in mind it does make a difference, because if somebody has a longer cycle, then you can delay the trigger a little bit, but ultimately you have to go by the follicular and follicle development. Because even if somebody has 35-day cycle and he has started medicines on day 3, then the follicle would develop somewhere around 12, 13 days. So it doesn't go to 35-day cycle, but many times you can, take it. Maybe she's less likely to develop an LH, premature LH surge, but you can't expect that it will be 35 days, or you can start stimulation little late on day 5. I think that can be done, and in those cases, the follicle would develop obviously later and may coincide with her more natural cycle. Yes. But if somebody has 25 days cycle, she is likely to develop premature rupture early, and her follicle is, you might have to give her HCG early. If somebody is, 30-day cycle, she may develop ovulation on day 14, 15. So little bit consideration you have to do along with endometrium and follicle, you have to take in consideration. Yes. I think Pramneet, you
If
can.
anyone else has any questions, can please put forward.
I think we can close now.
Okay, ma'am. Thank you. Thank you so much for this the great talk, Swati ma'am, Dr. Jindal for her expert opinions, and all the people who joined us today evening. Thank you so much.
And for
Thank you. Thank you,
appreciating the
everybody.
talk, Dr. Sujata, Dr. Deepa, Dr. Dechan, and everybody who is there.
Thank you, ma'am.
Thank you. Thank you, everybody. And bye-bye. Good night.
Thank you,
Good night.
ma'am.
Good night.
Thank you. Good night.